During the post-anesthetics recovery room care, there should be a strict vigilant one-on-one in terms of a ratio of one patient per one staff, and sometimes this could be even higher, because if the acuity and the demands of a child is higher in recovery room, then that would translate into more staff being involved, for example restraining a child from self-harm or throwing themselves on the ground, also containing the situation in terms of pain management. That ratio is a guide, and it may even be higher. However, for conscious older children where they are stable, the ratio could be negotiated from one staff to two patients. It is essential for us as perioperative nurses that we need to be reflective on our clinical competence and experience with pediatric patients. This is especially significant group in certain facilities where they constantly receive pediatric patients on ongoing basis. We need to be aware that we have achieved the level in which we could autonomously maintain pediatric airway, for example, do the patient assessment, be able to communicate with child and parent, because there are certain variabilities that we need to consider in terms of timely interventions, for example, when it comes to an airway incident. So the recovery room may require some modification for pediatric patients in terms of allocating specific bays. It is ideal to separate adults from pediatric patients if that's possible. The area needs to be modified and made friendly for the pediatric patient in terms of safety devices, maybe addition of pictures and toys. Some facilities utilize bravery awards for pediatric patients, utilizing colorful stickers, maybe making available DVD players. They could be really good communication prompts and distraction techniques for pediatric patients. We need to also reflect how our facility is aligned in terms of making the environment child friendly. If your perioperative setting doesn't receive pediatric patients, what I would like you to reflect is, imagine if the next 2 months, or in the space of 2 months, there will be pediatric lists commencing in your facility. How would you modify and how would you make the environment child friendly, and what strategies would you use to achieve that? Like the adult patients, during post-anesthesia care, administration of oxygen may be the highest priority in terms of airway management, and following the principles of looking and listening and feeling the airway, most assessment criteria starts with pediatric patients once they arrive in recovery room as such. In terms of challenges to clinical management of pediatric patients in recovery room, one of the most significant airway challenges would be the post-intubation subglottic edema. This will manifest clinically as a croup that may affect 1 to 4% of pediatric patients. It is seen very commonly from the ages of 1 to 3 years old. How it would manifest, that you see the child would have and become tachypnic, and they become tachycardic, and also they may present with a croupy cough. This reaction to intubation as an edema in the subglottic region would be due to the manipulation of the airway, because like we discussed earlier, the airway would be smaller, and multiple manipulation and insertion of devices will cause this sort of localized inflammation and edema in turn. Also, if surgical procedure happened to have taken place in the head and neck region, or it could be due to allergic reactions to the medications or any sort of nauseous stimulus. Also, subglottic edema could cause stridor, retraction of the muscles in the neck and in the chest. It may also manifest in hoarseness of voice, and it would cause anxiety and restlessness. In terms of subglottic edema management after intubation, the assisting strategies would be to assist the child to sit upright. If we could utilize humidified oxygen. If it's not resolved, steroids may be considered in terms of reducing that inflammation through medication management means. If the dyspnea or difficulty of breathing persists, where saturation is compromised, then re-intubation may be considered. That is, of course, after appropriate sedation has taken place, and then maybe a smaller size tube than the one that was used before. Hypoxemia in infants and children could be a potential risk. Children and infants could be susceptible to hypoxemia. If you look at the trends that are demonstrated in the literature in terms of airway complications post-operatively, 30 to 45% of children may experience some extent of airway compromise. This is mainly due to pediatric patients having a smaller functional residual capacity, and in the same manner having a higher demand for oxygen. General anesthesia, like any other patient, will reduce functional residual capacity even further. It may compromise the oxygen reserves even more, and any airway closure or compromise in patency and atelectasis would further lead to potential hypoxemia. Pediatric patients, because of the significant differences in anatomy and physiology of the upper airway, also could obstruct their upper airway easily, and hence that would contribute to the potential risk of hypoxemia even further. Oxygen therapy for all pediatric patients is highly recommended after any general anesthesia, and the assessment of the airway and the patterns of breathing, the depth of breathing, the effort of breathing, and the actual adequacy of ventilation needs to be vigilantly monitored and constantly monitored all throughout the post-operative phase until the patient's stable. Other complications that we can look at is obstruction in the airway, such as laryngospasm, and the younger the child, the more prone they might be to laryngospasm, and this may constitute a medical emergency where we need instant help. There may be requirement for suctioning the airway, continuous positive airway pressure with high oxygen flow, and constant monitoring, and collaboratively managing the situation. There may be requirement for the use of atropine to address the bradycardic episodes. Although up to 5 to 10 second pauses in the cycle of breathing in neonates is seen as common and normal, however, any cessation of breathing or apnea greater than 15 seconds could be associated with bradycardia, and this sort of cessation will affect the ventilation and oxygenation and may lead to cyanosis or the patient being really pale. The management of apnea, of course, with starting with vigilant monitoring and oxygen therapy, rousing the patient and trying to find out or identify the cause of the airway compromise or apnea via the differential diagnosis. If the child has had obstructive apnea, for example, surgical interventions may be applied to remedy that. Prevention of opioids or opiates in terms of further aggravating the apneic phase, and also if it's a day case, maybe overnight monitoring and saturation observation would be ideal. Emergence delirium. This is a common phenomenon seen in most pediatric patients who receive general anesthesia. It requires appropriate patient engagement and monitoring, and it could be highly challenging to the staff and also dangerous at times to the pediatric patient, because they may be at risk of falls and self-harm and dislodging, for example, surgical drain tubes and cannulae and so forth. We need to ask ourselves a question: how am I going to assess a pediatric patient whether they may suffer emergence delirium or not post-operatively? Literature reports up to 10% of emergence delirium incidents in pediatric patients. Some of the predictive risk factors could be for the patient group, being a healthy and young child, poor compliance at the induction phase, lack of intraoperative fentanyl use, rapid awakening or emergence, and also the patient not being premedicated. If we look at this number of predictors, we could go back to our history, for example, or the anesthetic record, and look at all these parameters, and that could be an indication whether there may or may not be emergence delirium presented in the child in recovery phase. Emergence delirium in pediatric patients clinically would manifest in terms of the child being inconsolable, the child crying and screaming, being very disorientated. This will in turn demand for higher nursing numbers and interventions, and it would potentially increase the length of stay in the anesthetic care within the recovery room, of course. There may be requirement for temporary restraints to ensure the child's safety. We may require pharmacological agents like midazolam or maybe fentanyl to sedate and calm down the child. It's been reported that due to emergence delirium, there will be accidental removal of surgical drains and IV lines. There will be increase in the level of pain, anxiety, potential bleeding from the surgical sites, and also minor injuries to the staff and the parents. Acute pain management in pediatric patient is a very important part of our peri-anesthesia care. The younger the child would be, the heavier we will rely on assessing behavioral and physiological trends in terms of determining the intensity and the type of pain, and hence alignment with management strategies. All the children will be able to self-report, where communication could be established with the child, and then reliable data could be obtained from children from the, say, ages of 3 to 5 and above, where reliability increases even more in terms of self-report, where we can obtain subjective data. With younger than that age group, we need to rely on objective methods of assessing pain, relying on behavioral and physiological cues. That in mind, using the child's age and the communication patterns and barriers, we need to utilize tools that are appropriate to the context and each child individually. In terms of peripheral nerve blocks, it may potentially pose a challenge for the clinicians because the surface anatomy of children are not as well defined as adults, and there's a huge variability in terms of depth and position of nerves in young children. Particular attention needs to be paid in the post-anesthesia recovery room phase to dressings, drain tubes. They should be assessed and observed for any ooze or excess loss and how tight they have been placed onto the patient, and also an estimation of urine output aiming to 1 milliliter excuse me, per kilogram in an hour or above. Recovery room is where we could further work on the temperature regulation to maintain normothermia and also prevent hyper or hypothermia. Pain and nausea and vomiting needs to be managed effectively. There should be no sign of active bleeding, and vital signs need to be stable or within the acceptable limits compared to the pre-procedure parameters. IV bangs and lines and cannulae need to be flushed with saline before patients are discharged. There have been episodes where remaining or residual amounts of propofol or fentanyl have been flushed on the ward and caused more sedation or further compromise of the respiratory events. Communication with children is a very unique set of competencies. Having a surgical procedure or a diagnostic or interventional procedure is quite a frightening and fear-inducing experience. Having the understanding of the context of the family, the parents, the child's age and social upbringing is quite essential for the clinician, and especially at the perioperative phases of coming to theatre and during the induction and postoperatively, where time is essential and tasks are critical to be undertaken at a speed reasonable to the staff and the patients. So the way we communicate and introduce perioperative business with the family and the child is quite essential in terms of managing their anxiety, how we equip them with education and how they can demonstrate their compliance is directly relevant to our level of expertise, of course. As health professionals, within the context of the healthcare we work, we are mandated by law to identify and report cases where children have been abused and neglected. This may happen in terms of approaching, after having made the valid assessment, approaching our line of management should we find any child abused or neglected based on our encounters in that psychosocial environment where we get in touch with the pediatric patient. We are also obliged to include the parent and family in the continuum of care wherever it's possible clinically. Pediatric patients pose a uniquely interesting challenge in terms of our ability to adjust to the demands of workflow. This is because pediatric patients come in with a variety of ages and sizes and weights, and usually the correlation of weight versus size and versus age may not correspond typically as it's highlighted in evidence or literature. Emotionally, children could be demonstrating different levels of dependence with regards to their carers and families, and that poses a unique challenge in terms of how you communicate to parents and how you communicate to children, and data collection and also clinical intervention. It is very critical to know that our level of competence working with children should be based on realistic expectations of ourselves and our reflective practice. There is very small margin for error. Any deficit in working knowledge and experience should be clearly communicated to the rest of the team, if we have no exposure or prior exposure to pediatric care, that needs to be taken into account in gradual adjustment. There have been reported cases where staff have assumed or exhibited overconfidence in pediatric care, where in critical situations a minor compromise in, for example, airway management has led to a huge adverse event clinically for the child, and the impact of this could be very far reaching for the organization, for the patient, and for ourselves. As the famous saying goes, that children are not little adults. We cannot apply a recipe formula in terms of paediatric anesthesia care for all children that would come into our care. There's a huge variability in anatomy and physiology, and hence we have to make those adjustments. The developmental changes that we see from the ages of neonate to adolescent would require adjustment in terms of clinical intervention, in terms of assessment, in terms of pain management, and in terms of psychosocial care. We need to individually modify the plan of care for each child. We need to identify their needs and their situational needs, and we need to align our interventions and nursing care accordingly. One of the biggest challenges for the paediatric anesthesia nursing roles is appropriately and timely selecting the correct equipment and aiding in the correct technique for the child and the age group. The way you may position your equipment or yourself closest to the clinician who is intubating for a 14-year-old might be very different from a neonate in terms of accessibility to equipment and holding and aiding the child, for example, and forwarding your equipment and or tubing the tube. This needs to be built through a competency learning curve on gradual basis with appropriate support, of course. We will conclude soon with reminding a few rather clinical facts that overall, when it comes to pediatric care, the relationship we build with the pediatric patient and the child, the more serenely we demonstrate our competence in terms of their care, the more reduced the child's and the family anxiety will be within the procedure, and the outcomes would be a lot more positive. If we have a child that goes under anesthesia anxious and crying and combative, and we could almost be certain that they will come out of anesthetics and emerge anxious, crying and combative. So you could apply this to your clinical practice and observe, make your own observations that this is very true. So we have a chance, we have an opportunity to interact with the child and family, with the family presenting to theatre before anesthetics, and transmit that serenity to them, and that assurance and that confidence, where they engage with us in a positive way, so the outcome would be positive towards the end. There are some references listed, part of your recommended reading, and specifically the two articles included here in the second slide of the references is very useful and highly recommended in terms of paediatric anesthesia care for pediatric patients. This is the end of this presentation. Thank you very much for your company.